So welcome everybody. It's really great to be with you this afternoon. Been looking forward to this session on health creating community spaces, what matters to communities. So thank you for making the time to be with us. Looking forward to a couple of hours. So a few bits of housekeeping from me. I'm going to be chairing the next 2 hours, keeping everybody in line and hopefully keeping us to time. There's a few bits of information that I want to let you know about. So all of these sessions as part of this series are being recorded and they will be available on the Health Creation Alliance YouTube page from mid-November. So you can re-watch to your heart's content. And there'll also be a short write-up from the session that will be made widely available as well. So it will also act as an aid memoir for you about the discussion, and we will be taking notes and reflecting on the discussion in the next couple of hours. We want ideally a bit of interaction, so do say hello on the chat box. If you just want to introduce yourself, let everyone know who you are and where you're from, and also use the chat function as well to share any views and observations that you've got, or any links to resources. I'm expecting lots of people will have lots of interesting stuff to share. So many of you will know that this is one of 6 events, in online and 1 in-person events taking place this week that make up the Health Creation Coming of Age series. So those of you who've been to previous sessions, hope you've enjoyed them so far, and we hope that you can join us for some of the other sessions too. We also invite you to join the Health Creation Alliance itself for free. So there's no reason not to. So do play your part in spreading and advancing health creation as well. This is a movement that we can all be part of. So would encourage you to do that as well. And of course, we want to have your views on how these sessions have gone. So if I could ask that you also remember to complete the evaluation at the end of the event. So these events wouldn't be possible without the generosity and support of our partners and sponsors who are supporting the events: the National Health Executive and Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solace, South Central West, and the Health Creation Alliance's patron, Lord Victor Adbawali and Lord Nigel Crisp. The Health Creation Alliance is delighted to be working with our partners, supporters and sponsors on bringing these sessions together, and without them, it wouldn't be possible to bring you this stimulating, timely and informative series event. So thank you very much. Now, what and why this Coming of Age series? Well, for the last 7 years, the Health Creation Alliance has led a national movement for health creation to address health inequalities. And for the first 4.5 years, things moved slowly in the right direction, but then a thing called COVID changed everything. You might remember. COVID-19 is just one of many destructive forces in our world today. It exposed the stark inequalities at the same time as making visible some of the more hidden aspects of how communities work, become resilient and thrive. I think it really concentrated minds on how inequality leads to poor health outcomes, but also on how health inequalities can be addressed by creating the conditions for communities to become strong through connections. So the last 2.5 years have been very different. Health creation is experiencing what might be described as a coming of age, hence the title. It is undergoing a metamorphosis, but there is a lot more maturing still to do. Health creation must become business as usual across all of our systems, alongside our efforts to treat illness and prevent ill health. So as we move into this new phase where much broader partnerships and collaborations become possible, our collective mission must be to build back together, including with those communities that experience the poorest health outcomes, and increase our efforts to make the necessary changes happen. So at the start of this series of events, Health Creation Coming of Age, we are issuing a call to action. So I'll read that out. For all integrated care systems to recognise health creation as equally important in addressing health inequalities as the treatment of illness and prevention of ill health, and to adopt and embed it as a way of working, making it business as usual across the whole system. So that's the call to action, and hopefully you agree that's a powerful call to action. And we'll seek to identify further calls to action throughout the event series. So part of my job is to try and reflect back some of the themes that are coming out of the discussion and try and reflect back to you. So if you agree with what I'm saying in terms of potential calls for action, do let me know. And if you disagree and want to suggest something else has more emphasis, then that's what this is all about. Health creation is about collaboration. So we don't want everybody's views in this, and then we'll try and make sure that we identify any of those further calls as we go through. So the next 2 hours, we've got a really great lineup of speakers who you can see their faces, I think, across the room. So we've got a mixture of presentations and discussion. There'll be a chance to ask questions of our speakers as well. And as I say, collaboration is our watchword. So do make sure that you take part in this and ask any questions and get your views across in the chat as well. And we'll also be having breakout sessions for those of you who are a little bit shyer. You can get around in smaller groups and have a more in-depth conversation about some of these things that we are talking about. Another opportunity to feed in your views. So I should say just also that I am the Chief Executive of Locality, and if you don't know what Locality is, it's the national membership network for local community organisations. So this whole topic and the things we're going to be talking about today, really, really, really interesting to me, and the work of our members across England and what they do around health creation. They may not know that they're involved in health and wellbeing and health creation movements, but everything they do is around supporting wellbeing and supporting communities for the long haul. So really interesting, and I'll try and reflect back some of those themes and lessons that we're all learning as we go through. So let's crack on with it. So first up, we are delighted to have our great speaker. Ria Horlock is the Head of Corporate Social Responsibility at NHS Property Services, and she's going to be talking about creating spaces for community and patient wellbeing. So Ria, welcome to the session, and over to you.
Much, Tony. Welcome everybody, and thank you to the Health Creation Alliance for inviting me along to this, giving us the time to talk a little bit more about what we're doing and what we've been working on together. So as Tony has said, I'm Ria Horlock. I'm the Head of Corporate Social Responsibility at NHS Property Services. For those that don't know, NHS Property Services, or NHSPS, are a government-owned company which exists to help the NHS get the most from its estate and ensure that NHS buildings are consistently fit for purpose so that healthcare professionals can deliver excellent patient care. We manage around 10% of the total NHS estate, which equates to just over 3,000 properties with 7,000 different customers across England. Our properties range from listed buildings through to state-of-the-art integrated health campuses, and they include a large proportion of primary care services such as GP surgeries. We have a broad range of property expertise within NHSPS, and we support our customers with all elements of how they manage their estates. So from town planning, space utilisation and disposals, right through to hard and soft FM, construction and energy management. My role within the business and my team is to lead our approach to corporate social responsibility, essentially how we can identify where we can have a greater positive social impact on top of the essential role that we play within the NHS system. Our CSR strategy focuses on how we can protect, improve and promote the health and wellbeing of the communities that we operate in, supporting community-based health initiatives and addressing key social issues to improve long-term population health, lessen health inequality, and ultimately help to reduce pressure and demand on NHS services. Exactly as Tony's just mentioned in his introduction, we know that some community groups can find access to healthcare relatively easy, but across the country and even within local areas, different people are more likely to experience poorer health outcomes due to a range of factors that are just outside of their control. The NHS's long-term plan and NHS England's priorities for this year both talk about how these health inequalities and how NHS services can help to bridge the gap and reduce the difference in health outcomes that different people experience. For us at NHSPS and other organisations that are responsible for estates, there's a key role for us to play in this reduction of health inequalities. We want spaces that not only put people at ease when they're coming in for their clinical services, but also spaces that can allow them to get and stay healthy through a range of community-led interventions. We manage a range of different programmes to help reduce some of these inequalities and help improve people's overall well-being. But the key one for today, most relevant to what today's discussion is all about, is our community-led health programme, particularly how we can better use vacant areas of the NHS estate to support the growth of social prescribing networks. Over the last few years, we've been reutilising various internal and external spaces in our estate for local charities and community groups that are delivering important services for their community, helping to strengthen the capacity in the voluntary sector to meet increasing demand due to the growth of social prescribing. Since 2019, we've created more than 60 of these different spaces across the country. These sites vary from very small GP practice courtyards that have been converted into a growing space for a patient group to get together, socialise over a shared activity, right through to sort of larger multi-use internal spaces, which can be used by a number of charities and community groups to deliver a range of services, such as one at Erdington, which we will be hearing a bit more about later on today. Using feedback directly that we've had from our sites, we estimate that around 35,000 people were directly impacted by our social prescribing spaces last year, and we're continuing to work with the spaces we have created to ensure they're able to reach the people that need them, and we're offering the support that they need. While we've been delivering these spaces for a couple of years, and we know that they are making a difference in the communities that they're in, we were conscious that we didn't know enough about what people really needed and what people really wanted out of these properties. We were creating the spaces with the community groups that would use them, but this was done only on a site-by-site basis, and we didn't have any wider information to help shape the overall programme. We were also only doing this for the spaces we were creating through our social prescribing programme, and we weren't taking any of these learnings into our wider estate. So all of this is why we started the piece of work with the Health Creation Alliance. We wanted to understand what matters to people in the communities that we operate in order to ensure that our estate is best fit to improve their health. Working on this report with the Health Creation Alliance has given us that really rich insight into what matters to some of these different community groups, so that we can make sure that our estate works for them and they're able to rely on the NHS to improve their health and wellbeing too. Some of the key recommendations in the report are things that possibly we might have expected would come out, or things that we might have already heard from our customers and communities. But there was so much in the report that we would never have known until the Health Creation Alliance really took the time to sit down with some of these community groups to really understand what it is that they've got to say. So, for example, while we knew that some groups may lack trust in the NHS, we were surprised with just how many times this came up and across how many different groups, and also in very different ways. So from feelings that there was perhaps a bit of an agenda behind the interactions they were having with the health system, right through to feeling blamed or branded as troublemakers. While some of this feedback possibly relates to interactions with clinical teams, there's still so much that we and lots of other estate providers can learn from this, including how our colleagues, who might be receptionists or people that you would find on a site, might engage with patients when they're there, and also how we can create environments that help to facilitate better relationships and better trust with clinicians. There was also some mixed views on the terms social prescribing when we refer to the programme that we've got, which was a really interesting thing to come out of it. When we talk about the programme, we do try and talk about how it's there to improve vacant spaces for community groups, and we talk about the voluntary sector and community engagement, but we do still label it as social prescribing, which can be quite a clinical term. So certainly in there with that feedback, there's a lot for us to think about in terms of how we ensure that the end users of the space and the groups that are in them feel engaged and they feel empowered and they feel that the properties are for them, but also still showing that we're aligned with NHS's social prescribing programme and social prescribing guidance. It was also assuring for us in some of the recommendations, they were areas that we'd already looked into or already trying to address. So for example, people from the disabled community group had asked for access statements to be published for the public to be able to see, which we had already done for nearly 400 of our properties through our partnership with Access Able. So it helps to reinforce that what we were doing was along the right lines and we just need to do more of it. We've already shared the report with some of our colleagues internally, and we'll be spending the next weeks and months ensuring that every area of our business is aware of the findings that have come out of the report, so that we can start to improve how we do things and factor this information into how we make decisions. We'll also be sharing the report and the findings with our customers, our stakeholders, and other areas of the NHS responsible for estates, so that the impact of this research isn't just limited to the 10% that we own, but it can be used by everybody. I would really recommend, of course, that everybody on the call has a read through the report. While the research is aimed at NHS spaces, there is so much information in here that's relevant to all areas of society, and I hope will make us all a bit more mindful about how we can be as inclusive as possible in all that we do. For example, I've already had some really interesting conversations with colleagues in our people team, looking at how we can use some of the insight from the report to shape our recruitment processes and assess if all of our HR policies are fit for the diverse workforce that we have. We have created a page on our website that shows the full report and also some shorter materials that provide a summary of the findings and the recommendations. So I make sure this all gets shared after the session so that we can look through. I'm looking forward for the rest of the afternoon to hearing from some of the individuals directly that were involved in the making of the report and hearing more in their own words about what matters to them. I'm also very delighted that my colleague Rachel Taylor is here from NHSPS, along with Debbie from one of the spaces that we've created in Erdington. And I'm just looking forward to hearing more, as I say, in their own words from them about the difference that these kind of things can make. Before I hand over and hand back to Tony, I just wanted to say a big thank you to all the contributors of the report for taking the time to tell us what matters. It shouldn't have to be on these community groups to tell us what they need from the health service, but I'm so grateful that they have, and I hope that they know the value that some of this insight will bring. And finally, of course, a big thank you to the Health Creation Alliance for their dedication to this piece of research and for bringing us all together today. That's all from me. Back to you, Tony.
Thanks very much, Ria. So really interesting there to hear about the impact of that process, actually, in terms of the way that you've thought about things and the impact it's had on some of your practices already. So I'm sure somebody will put a link to the report in the chat just so that somebody has access to that if you want to have a look, and do encourage you to have a look. But really coming out powerfully around some of those issues, you know, that perhaps you hadn't thought about before the engagement with the community around trust issues and different communities who have perhaps an unequal feeling of trust, and also those kind of language problems as well, which I think comes up in work that I'm familiar with around the country. So thank you, Ria. If you're happy to answer any of those questions in the chat, if you're around, do keep the conversation going in the chat. So we're now going to move on to our panel discussion. And this is going to be facilitated by Merryn Simpson, Chief Executive, of course, of the Health Creation Alliance, who will be familiar to many of you. Merryn, do join us, and you're going to be joined by 4 great report contributors, and you're going to talk through digging deeper into the findings of the research and what this actually means for us.
Thank you, Tony, and thank you, Ria. And over the last year, the Health Creation Alliance has undertaken this research on behalf of NHS Property Services, and we are delighted that you have chosen to launch the report at this set of coming of age events today. We're so pleased to hear from you, Ria, that you know, Property Services is taking the findings of the document on board, and some of the ways in which you're doing that. And we've really enjoyed working with you to make this report, you know, come to bring this report to you, but also to help to sort of embed it in what you're doing. So that's really great to hear, and I'm sure that our contributors today will be pleased to hear that as well. We often do a short piece at this point in these events to explain what health creation is. We have our own framing, the 3 C's: control, contact and confidence, and 6 features of health creating practices. But this afternoon, we're hoping that that will come out in the session, that it will emerge. And so we're not going to dwell on that. But if you do want to find out more about what health creation is and to have a bit more of an introduction to that, then I suggest that you catch up at some point with session 1 online from mid-November, when it will be available, and you'll receive, you know, more of the details. But today we're focusing on this report, Creating Spaces for Wellbeing, and the aims of the research were twofold, really. The first is to uncover what it is about spaces and the processes involved in making those spaces available that helps or hinders underserved communities to create health. And the second aim was to identify some of the different factors, as well as some of the common factors that different communities value about spaces. And we worked with 10 different community groups, and they are in no particular order. They were carers, people with or recovering from drug and alcohol dependency. There were rural communities, there were people with a learning disability, people of Somali origin and heritage, people with experience of mental ill health, people from the LGBTQ plus community, women from South Asian origin or heritage, disabled people, and people from the Roma community. So a very broad spread there of different communities. Obviously, we recognise there are many, many more different types of communities out there that we could have talked to. Once we'd chosen those 10, which 10 we were going to talk to, we started by building trust with those community groups. And we approached them through our trusted members, because we're connected through our membership to many groups, and worked with anchors to reach people. And we undertook, when we started the focus groups, we did that in a very conversational style. So asking some open questions to start with, to get the conversation going, and very much going where the group wanted to go. So we felt we were sort of hopefully in tune with what particular group was thinking and wanting to talk about. And we dug deep, because we're interested in people's lives, and we wanted to understand the why as well as the what. So not just what matters, but why it matters. And the groups were very generous, and they told us a lot. So we want to extend a big thank you to all those people who have contributed. And we hope that we worked that in as good a way, as we could. And each group we spoke to had its own thing going on. And you can read the detail of that, of what matters to each of those 10 in the report. But one of the striking findings for us was that there was also a lot of commonality between what matters to the different groups. And so you can read about that as well. But rather than me talk more about that, we're going to hear from some of the contributors themselves. So I'd like to introduce George, Ruby, Ash, Mead and Lisa. And they're going to start by introducing themselves, each in turn, and to tell us which group they identified with for the purposes of this report. And then they're going to spend a couple of minutes just telling us what mattered most to that group and why. So 2 or 3 minutes on that. So George Fielding, would you like to go first?
Indeed. What's the use of 2 strong legs if you only run away? What's the use of the finest voice if you've nothing good to say? What's the use of strength and muscle if you only push and shove? And what's the use of 2 good ears if you can't hear those you love? I'm here as a social care innovator, but also somebody who identifies as having a disability, and therefore it is incredibly important and rich to me that within this wonderful report that there are 3 key features, 3 key points that I think are very useful to everybody. One is that we are an increasingly disabling society in number, and actually disability is becoming more and more hard to define. What's the point there? But with any form of inclusive design, invest early, invest properly, invest once, it pays off. So the second point connected to this is that for people with disabilities, the effort starts in the home. The personal is the political, and also private, in the sense that when you access a space, if you don't know it is accessible, if the information is not up to date, if the logistics behind everything is too much, and in terms of quantity and in terms of effort, you will not leave the house. So whilst it is, and this is a striking point that was made during the contributions from my side, whilst it is perhaps more convenient to send somebody a Zoom link and do everything virtually, just because people with disabilities can accept that link and it's more convenient to do so, doesn't actually mean it is accessible. Because if they are stuck within their own home, then actually their world is as narrow as it has always been. So the point there is that and Ria made this incredibly articulately, is that these properties provide a space, a community in themselves, but they are within a community. And therefore, perhaps the accessibility of NHS Property Services from a disabled point of view is demonstrated by the fact that can do people with disabilities want to make the effort to get in, and do they know, thirdly, who is accountable for such things like maintenance, and actually that if this is a community space, do they feel, is it clear in how that space is run, in how it feels, that everybody has a duty, a responsibility, and there's a benefit to everybody making that property as accessible and inclusive as it can be. Those are the 3 key points from the kind of disability working group, and it's an absolute pleasure to launch it alongside you, because philosophically, if you feel as if you have a community and a space, whether that be literal, spiritual, or otherwise, you're a healthier individual. And I believe we can gain comfort in the fact that people felt confident and able to contribute to this report. So with all things of this nature, the proof is in the pudding, but we all desperately and are excited by the idea that these learnings can be spread far and wide, and will support Ria and her whole team in doing so. But that's just the disability side of things.
Thank you, George. That's excellent. We're now going to hear from Ruby. So take it away, Ruby.
Yeah, hi, I'm Ruby. So I've been volunteering for an alcohol and drug recovery place, and so one of the first things that we have a massive issue with, which I think a lot of people who are facing any sort of addiction that want help, is going to a location where they're not going to feel like they're judged, but also not like it's specifically alcohol recovery or addiction recovery, because it can make it very sort of overwhelming and daunting to go in to face anyone, to ask for help. So having somewhere that's a sort of not discreet necessarily, but not specifically for addiction or specifically medical, a place that's comfortable for someone to go in and ask for help and possibly attend meetings without being seen by others that they might not really want to be seen by, or even having sort of alternative entrances to a building, so that, again, it's not so daunting. It doesn't put people off from seeking help, which I know a lot of people, myself included, will put off seeking any help because they're nervous about who they're going to see, where they're going, and all of that. Another one that has actually come to light a lot through COVID is online meetings, but also face-to-face meetings. Both have a lot of pros and cons. So having a place that can facilitate both online and in person, or even hybrid of both meetings, would be massively beneficial. Through COVID, we were only able to do meetings online, and personally for me, this will come out later, but I have a disability, which means I can't go into physical meetings. So having the ability to attend a meeting online was what helped me, recover from my addiction. For other people, however, that need to have a face-to-face option, there are people that have childcare. You can't really attend a meeting whilst you've got your child running around in the background, and people that they can't attend a meeting like that when their family are around, because the family might not know about their issues. So the important thing would be being able to facilitate both online and in person. And the final thing I wanted to say about was the peer support. One of the biggest things I've found throughout my journey with recovery and with other people I've spoken to is people who manage to get over, fight an addiction and get into recovery want to pay it forward. Or everyone will, pretty much everybody who does it wants to be able to help other people and help them before they get to a point really where they need help as badly as we have. So, having the ability for volunteers or peer-led groups would be really, really beneficial as well.
Thank you, Ruby, for just setting some of that out so clearly, really helpful. We're going to go to Ashmead next. So Ash, looking forward to hearing what you have to say.
Hi, my name's Ash. In terms of the group that I most identify with, it would probably be the group from the mental health group. In terms of my own struggle with my mental health and my own journey, suffering from PTSD and bereavement, depression, owing to things that happened in the past, living a chaotic lifestyle. So in terms of the things that stood out most for me, from the features, and it links in with the themes as well, was mostly around self-focus and self-organizing, mostly because my journey with mental health has mostly been a private one, and mostly been self-driven. I think it kind of ties in with the main part of my argument here, which is around self-sufficient communities. Because most of my interactions with the wider society when I was living how I was living was mostly through informal networks. So whether that would be for conflict resolution, that was informally done, whether that was for support during a time when I was homeless, that was informally done. So I've seen the power of informal networks and communities building up their own resources. It also brings me to another theme that stood out for me, which was diverse perspectives and good locations. Location and premises is key from my point of view, mostly because my experiences of mental health and my lived experience of it comes from living a criminal lifestyle, basically. And location is key. I think maybe the report had captured some of this, but even on one occasion, I remember speaking to a young guy, well, a group of them, and these was what people normally label the bad kids in the area. And we're there now having a little chat. And I was saying to them, because they're saying, oh, there's nothing going on, but I'm saying there's a place called the Tower just up the road. And why don't you go there? They got everything there. Huge new facility just been built. There was like, nah, because the way it is, people can see them off of the road. That road's a main road. It attracts all types of people, whether that be friendly faces or unfriendly. It's the way that they can get in, they could be unseen while seeing you. So that was one of the reasons why. And even reflecting upon another occasion where, that same place, the Tower was there. There was also a place, let's call it in the north. So the Tower's in the south, this other place is in the north. It had less facilities, quite run down, but it attracted more youth from the area. And to tell you the truth, it was very much community controlled in terms of, it was one of the bases that they used to do the sewing for the carnivals. It was one of the bases that they used to use for like gang mediation meetings and whatever. And it was one of the bases as well for youth workers. So, you know, location for me is key. And then also as well, another key one I identified was like having an inclusive design and having people have some kind of control over access to the area that's specified. Because like I said, with the tower that was in the south, call it, it was very much run by, you know, official organizations, Mr. Jacket and Tie, sign in and sign out kind of thing, where the one in the north, like I said, even though it was run down, it was much smaller. Sometimes it could be a hotspot for hotbed of problems as well, but it was very much community controlled. It had a lot of history to it as well. It had been standing for a lot longer. It had attracted a lot more personalities through there. So it was a lot more treasured and probably a lot more fought, like resisted when they took it off of them, basically. I don't think I would have seen that kind of resistance if the tower was shut. So, yeah.
Thank you, Ash, for being so candid and giving us such great insight into, you know, some of the realities and what actually matters to, you know, some parts of the community. And, you know, it's insight which we wouldn't gain unless you were here with us, helping us to understand and navigate that. So thank you really so much for that. And we'll go on to Lisa as well now, finally, and who's going to talk. Well, you can tell us what you're going to talk about, Lisa.
Yes, no, I'm holding it all together. That's the great thing. I'm Lisa, and I live in the rural North Yorkshire, as I call it, back and beyond Ruralsville. And I was one of the rural contributors, the anchor for the project. So I gathered the information from various different rural communities, talking a formal one-to-one interview. We held a focus group, and we also explored the idea of using a survey so that people could contribute. Because one of the things that we found, well, there's three main findings. So the one that we really found that there was a key issue was around transport. So to actually access people's views just in itself was an issue, because of people being able to contribute if they're, particularly with the low income aspect. So I think that one of the main findings, if I kind of like outline that the first one was then around transport. The second one was around actual accessibility and all the red tape and issues around actually trying to book rooms at a local level, because the control seemed to be at a national level. And then the third one would be around enabling community leaders to get much more involved in the participation and running of community services. So if I take the first issue, was, I'm slightly nervous, so just bear with me. I'm trying to stay focused. I think the first issue that was really difficult for people was actual transport, and not necessarily in terms of obviously rural transport's fine if you have your own car, but not everybody drives. So there's a whole intersectionality across the board of low income people, but particularly also people who've got disability or older people not having access to facilities. So just making an actual simple appointment to go to a GP or to go to an activity where most of the activity tends to focus around market towns. If you're in a rural community village or hamlet, just to access a GP appointment can be an all-day event, to negotiate around buses and bus timetables, and a lot of what I would call synchronized coordination has to occur just to actually get a doctor's appointment if you're going in on a bus that only runs once a day from the village, or in some cases once a week. So I think that was a really, really difficult issue that could be explored more, obviously, in detail. I think the second issue was around the actual accessibility for people. Once people actually manage to get to a place, quite often it could be quite a dilapidated sort of, they're not necessarily buildings that are fit for purpose, because quite a lot of the rural buildings have been left to, for whatever reason, that they're not necessarily kept up to the same sort of high spec that maybe some of the more urban places are, which, without that sounding wrong. So I think one of the accessibility issues was around how the NHS property owners could become the problem solvers, because they could actually help some of the people who are trying to organise things in the communities to actually make more use of the buildings. So the red tape that's associated with actually trying to book the rooms could be actually looked at, and I think that some of the findings were saying that making the rooms to be actually easily bookable. So, for example, one project was across the road from a GP surgery with an empty vacant room that could have been accessed and utilised all through the COVID process, all through that period, but there was no way of booking it. So the frustration was held by the whole of the community, because it was just difficult to actually be able to utilise the room because of the red tape, health and safety, safeguarding issues, etc. So if the NHS properties could actually become problem solvers rather than gatekeepers, and I'm sure that it's mutual, it's a win-win for everybody, because the community can then get involved in using the spaces, and to a certain extent the community can get involved in certain aspects of the upkeep, not all aspects maybe, but certainly weeding gardens around buildings and things that all feed into community initiatives. And I think the third aspect, the third finding that came up, was around supporting community leaders to develop the spaces, the vibrant community spaces, so that there's a lot of people within the communities who could be supported. So volunteers, a lot of volunteering goes on within the community, certainly within rural communities, and with full support, more volunteers can progress and develop roles that can be paid roles, so that the pathway from volunteering, particularly in poverty, the volunteering pathway through the using of the community space, yet another win-win for everyone. And I think, the overall connection to the health creation aspect is that the more communication and the more contact and the more people can actually get involved in that, the more confidence that they can get involved in, to some extent, being part of their own recovery program. So people can actually be doing it for themselves with very, very little input from, I always look at it in terms of finance, it's actually a win-win for everybody, because the communities can self-generate that support for each other. And I think back to what I think perhaps Ruby touched on it, the whole idea of peer support and people supporting each other through those processes. And that sort of way of looking at it is perhaps, I'm maybe going into cost benefits, but I'm just thinking it just works out cheaper. And also, in terms of proactive prevention, it actually helps people prevent things from going wrong, because the community can see Mrs. Smith struggling to get to her health appointment for her heart tablets, and somebody can offer a lift. All that sort of thing can actually be self-sufficiency in action. Anyway.
Excellent. Okay, well, thank you, Lisa. That was excellent. So very helpful and authentic contributions from everyone here. All I want to do really the last few minutes is to just draw out some of the things that that I've picked up that are actually common to you all, although you've expressed some of the things that matter specifically to your community, or the community that you identify with for the purposes of this project, let's say. But the thing that came out to me was access in many ways. So we've got access to the building. So we've got this in terms of sort of, if you provide us with more information, an access statement, for example, that will really help. It also, access in terms of stigma. So things like confidentiality of access, being able to access a building without someone knowing why it is you're going there. That's really important for Ruby, and maybe online access is part of that part of the sort of the portfolio of ways that you might be able to access a building. So that came through. And then the booking, the room booking, not a sort of red tape type room booking system, but one that is quite enabling. It is helpful. So it felt to me, and then the location issues that you spoke about, Ash. I mean, that's somewhat deeper than simply access to a building. That's more about where the building is in the first place, but it's still about how people think about whether they want to go there or not, and what lies behind that. So there's something there about the location as well being part of access. So that issue of access really does have a number of elements to it. But the fact that if we can access, then it provides a benefit to many people. So that came out, and that's we pulled out a number of big themes, 8 big themes, in fact, from this report. And that was one of them, access, transport, location, etc. Well, location was the second one, but the other one I want to pull out here, which you've just all talked about almost as well, is this self-organising and being self-sufficient. And you mentioned peer support, Ruby, being really important for people who are recovering from drug and alcohol issues. But Ash, it seemed to be all about self-organising for you, and I know. Lisa, you pulled out as well, is wanting to bring on community leaders to manage and run those buildings. And George, I think that this was also in yours, really, because you were talking about not just disabled people getting together to provide the access statement, but actually let's do it together in the everyone who uses the building, because it matters to everyone that their friends can access it, etc. So something there about self-sufficient, and we'd like that locus of control to move, to shift from it being an NHS building to somehow being much more, the ownership feeling, the community feeling they have ownership in all sorts of ways. And that's just 2 of those. So those are just 2 of those common those things, those big themes that have commonality. And there are 8 of those in the report. So have a look at that. I don't know. I'm going to put it back to you all now to sort of say what you think about that and what lies at the bottom of that, because of course intersectional identity came up as obvious. It was implicit throughout the whole project. No, very few people mention the word intersectionality. That's but we know you've got loads of identities. You've identified as for this project as one thing, but tell us more about that and why you think some of these commonalities are there.
If I may say so, Maren, I don't want to rubber stamp it, but I've been sitting here and smiling because I actually agree with everybody's contribution. There is agreement here, and there's a certain desire and, dare I say, urgency to make this happen. But also the word that keeps coming back to my mind is authenticity. The shirt and tie, and the idea that a space is for everybody, and if the NHS are truly to make the most of their spaces, it goes without saying that everybody has to feel welcome in those spaces and want to use those spaces, and to know that they're there. So there is a that, and I actually think this comes down to many things about leadership and actually the intersectional nature of all of this, in the sense that that if we are to create a self-organized, healthy society that supports one another, then actually we've got to have the power to move and to act and to and to and sometimes, and I certainly know, to make good things happen, all you sometimes need is a room, a chair, and one person in that room to really understand what you're saying and want to speak to you. So I do believe, this is simply fundamental to the health of our society, because healthy buildings create healthy communities. But those are just kind of my wider reflections on whatever be said.
I think what you're saying, George, is really important, because I find, as within the rural communities that I live in, I find that, and I love that phrase, Ash, of the Mr. Suit and Tie, because I feel like I'm having to turn into Mrs. Suit and Tie just to get heard. And I think that coming up with that rearranging of the power of people kind of quite often take the suit and tie off to come to our meetings or to come to the community. They put the jeans on and they put the trainers on and they dress down. But I'm finding that I'm having to dress up so that I'm taken seriously. And I find that that's a really interesting, it's just got me thinking as we're talking now, that's a very interesting, do I need to become Mrs. Suit and Tie to be heard, or do I not? And I think that that's a real dilemma for a lot of people across the board, which I just want to throw that one in there, because it made me think, oh gosh, I'm dressing up when really should I be doing that?
It's the concept of masking, isn't it? Which in the autistic community and other communities has been a phrase for a long time. But if you have to pretend to be somebody else and present as somebody else just to feel comfortable, then that environment's not right.
I think it's just to be heard, because if as a person looking at it on the broader level, if I go in my jeans and my t-shirt with mud on my boots from the farm, as it were, I'm not taken as seriously as if I go in my suit and my jacket and look more professional. And I think that is just an image issue, isn't it? Which is, I don't know, I'm both of those. So just, I don't know.
So in the report that did come up in terms of, welcoming environments, inclusive culture, and facilities management, being either led by the community or, at least trained managers, so that they understand some of the cultural issues. Because of course, it's not just about dressing up or down; it's about all sorts of different ways that people might dress and present. But Ash and Ruby, I don't know if you've got any sort of comments before we bring the session to a close. And I'm sorry, I haven't been keeping my eye on the chat. I've been more interested in what you've been saying here.
I was like, I was just going to comment on one thing in the chat that leads back to what George and Lisa were talking about, and the whole being like how we want to be perceived and not sure. And somebody said something about the true experts. I can't find it now. But it just, I think meetings like this one right now, it kind of goes to show that, you'd think everyone's all suit and tie and everything, but we've just got to be ourselves, and having lived experience. And that is one thing that comes up a lot in addiction recovery and peer support, is lived experience. Because who's going to know more about what you're going through or about something than you and your lived experience. So yeah, it's kind of hard, because you want to put across a great first impression, but also, I think you just got to be who you are and use that.
So what about sort of multiple identities, the intersectionality point, and someone mentioned multiple function, multi-purpose spaces there back then as well. That was very, very strong. Most of the communities that we spoke to wanted to use spaces that were used by many, many other groups, and they people want to mix with others. Ash, I know you have something to say on this.
Yeah. So I was actually going to come back to that intersectionality thing, because like I said, my experiences in terms of my lifestyle prior come from mental health, come from homelessness, discrimination, disability, what do you call it again? It's a hostile environment towards immigrants, like all these things I've experienced. So it's to show that maybe we should look at health inequalities as a thing that is intersectional as well. You get what I'm saying?
100%.
And if that is the audience that's being attracted to these premises, then the premises have to reflect that intersectionality as well. Because like I said, well, said in my head anyway, there's many a time within my own profession where I work with support work, and even with my own personal experiences where I've gone to one place for one thing and ended up with a benefit for something else. Do you understand what I'm saying? So there's been times when I have went, like, and it happens in normal life. There's been times when you've gone to the shop for one thing and you've seen a bargain for something else. And that's exactly how like signposting and services work at a more informal level, but you'd be surprised how much those informal things can attract audiences or help that individual case or that group that has access to that kind of thing. So, like I said, this other place in the north, coming back to my analogy, this other place in the north there, it was being used for multiple things. So youth workers, so you got all the so-called bad kids and the good kids as well coming into the place. You've got sports activities taking place there. So then you get in that kind of crowd as well. You had carnival suits being woven there. So you had that. So it wasn't just used for one thing. Do you get what I'm saying? And because it's not used for one thing, like Ruby was saying before, it's not necessarily stigmatized. And then at the same time, in terms of what I was saying, in terms of the location of the premises, there are certain premises, well, in the community I live in the inner city, Birmingham anyway, there's certain roads, certain things that are known informally as other things. And those things, that kind of shapes what that building is about, and it can kind of shape who it attracts and what benefit, what kind of output it's giving. So that is my take on intersectionality anyway.
Thank you so much. I'm just looking at the time and I realise we're really at time now. So unless anyone's got anything burning just to say in about 10 seconds, which maybe Ruby, I think you might have done. Do you want to just finish, and then we'll hand back to Tony? But thank you all so much for your input to this today. But Ruby, do you want to have the last word?
Yeah, I was just going to make a quick point about how intersectionality is so important with everything. Because, for example, me being able to use a hybrid in online meetings to get sober, and because of my disability and anxiety, I wouldn't have been able to attend meetings in person, because not rural, but I'm in a small enough town, I'd have to drive 40 minutes to the nearest meeting. And just little things like that, you don't realise how much little things overlap that can make a world of difference. If I hadn't gone to that meeting, I wouldn't be sober today, you know. So just intersectionality really just everywhere it comes up in the smallest things you wouldn't even realise. So yeah, I'm glad we're doing this, and thanks everyone for having us, obviously.
Right, well thank you all ever such a lot for making it here today and for talking about this. And this is the sort of conversation that needs to happen in localities as well. All these 4 speakers are from different parts of the UK, but actually, we need to bring people together like this in a place around a particular building and have these conversations. So I'm going to leave it there. Thank you very much, and hand back to Tony to take us on to the next session. Thank you.
Thanks, Maren, and thank you to our amazing panel of speakers. I mean, that was really just rich information. So thank you so much for your contributions. Really powerful that we have your voices heard, actually, and have these conversations and take them on. I mean, I just think, we're thinking about calls to action. So remember, that's our task as we go through and as we listen to the speakers and get inspired by the contributions. But just for me, just reflecting back before we move on, we might want to think about these as potential calls to action as we go towards the end. It's something for me came out strongly there about being authentic, so that authenticity. So for service providers, is that about being authentic and letting people be themselves? That whole conversation about not having to dress as someone else, you know, and not feeling like you can't be yourself and bring yourself to any occasion. Something about problem solving rather than gatekeeping. I don't think many people go into public services to be gatekeepers, but we kind of project that onto them sometimes because money is tight and things. So how do we enable people to become problem solvers, not gatekeepers? I think something for me about the process in all of this, the process is really important about listening to people, you know, so ask people what accessible and inclusive means to them rather than assuming from the very beginning and setting things out. And as we heard, there's lots of difference of that depending on who you ask and who you talk to. We need to have lots of voices. And then finally, that point about multi-purpose spaces, you know, making sure that we trust existing places that are multi-purpose, that don't feel threatening to go to. You know, you don't feel stigmatized by going into a place because lots of people are going there for lots of different reasons. All really interesting stuff for me. Anyway, those things to think on. If you've got any, if you want to tighten those up, if you want to disagree or agree, get them in the chat and we can try to think about those calls to action as we go through. So moving on swiftly, we've got our next couple of speakers, and this session is around a gold standard site for social prescribing. So delighted to be able to join Rachel Ann Taylor, who's the social prescribing community manager at NHS Property Services, and Debbie Bates, who's the health wellbeing and community services manager at Whitton Lodge.
Lovely, thank you, Tony. Good afternoon, everybody, and thank you for joining us. Debbie, I'll let you introduce yourself just after. So just to kind of start, my name's Rachel Ann Taylor. I work for NHS Property Services. So you've already heard from my colleague Ria this morning, this afternoon even. So yeah, just a little bit about it. So I'm kind of overseeing the social prescribing programme that we're running at NHS Property Services. And I've got the lovely Debbie here that's joining me this afternoon, just to kind of talk a little bit about one of our gold standard hubs, which we call Erdington Wellbeing Centre, which is also known as Whitton Clinic. Debbie, do you want to introduce yourself?
Yeah, thanks very much, Rachel. Yeah, so I'm Debbie Bates. As I've already been introduced, I'm the Health Wellbeing and Community Service Manager, and I work for Whitton Lodge Community Association. We're based in North Birmingham.
Lovely, thank you very much. So we're just going to talk a little bit about how Erdington Wellbeing Centre or Whitton Lodge kind of was formed, how it came about, and what's actually happening there now, and how people are accessing the services there. So just to give you a little bit of background, the space was an urgent care walk-in centre, and it had actually been vacant since 2020. The PCN and the people that used the services were quite involved in the creation of the Wellbeing Hub, and I believe Whitton Lodge had community volunteers that were heavily involved in the setup as well. Debbie, are you able to kind of tell us what it was that Whitton Lodge was looking for and how it was working with NHS Property Services to get this hub up and running?
Of course. So yeah, as an organisation, we do manage 200 properties, and we have an extra care sheltered scheme as well. We've been providing services and support for over 35 years. And like I said, we're based in Perry Common, North Birmingham. Alongside the housing, we also have our internal teams, which are health and wellbeing, community life and volunteering, housing, employment and skills, as well as training. So we, in the northern locality, we support 7 wards across Erdington. So that's Castle Vale, Erdington, Gravelly Hill, King's Standing, Perry Common, Pipe House and Stockland Green. And we needed something and somewhere that would appeal to a range of people that we support who have quite multicultural backgrounds. And there was a range of health needs across North Birmingham. When I say North Birmingham, that covers Erdington and Sutton Coldfield, who have just a population just over 197,000 people, with some health needs, including obesity, with Perry Common and King's Standing having quite a high proportion of people who adults overweight in the locality, respiratory illnesses, so COPD and asthma, 2 of the highest prevalences in Erdington, cancer, with 5 Birmingham localities, the north had the second highest and still has the second highest prevalence for cancer and some teenage conception, with Castle Vale and Erdington and King Standing being the highest. In addition to those needs, we have obviously lots of people that have gone through COVID, whether they've had COVID, and unfortunately 621 deaths, which equate to 17.3% of deaths in the locality. And there's quite a high rate of unemployment, as well as clusters of overcrowding and high proportion of children with special needs. So as an organisation, we had been hiring lots of local venues to try and use community spaces, including local cafes, so that we could reach as many people as possible and facilitate some groups and activities. Which was not always easy and or convenient. And it was through conversations with NHS Property Services that Erdington site became available, and the location of the premises was just perfect due to its central location. Obviously had great transport links, parking, access and accessibility. So we was able then to reach lots more of our community across the Erdington constituency. So working alongside Charlotte from NHS Property Services, we had an extremely positive experience, was able to work out the finer details of the agreement, as well as being fully involved in the decorating and the furnishings of the actual building itself, to ensure that it was a warm, welcoming and suitable for its delivery.
Lovely, thanks Deb. I think you've touched on kind of a couple of the main points there as well, because linking back to the report, we was talking about kind of the 8 main themes. So you touched really nicely on about the location and the accessibility of it. And this is why the space was really good for a multi-purpose hub, wasn't it? So Deb, are you able to kind of explain to everybody the types of services that you're running on a daily basis at Whitton Lodge, and how is this space used to support the local community? Is it drop-ins? Is it bookings? Just talk about kind of what happens on a weekly basis, please.
Okay, so as well as the services that we currently provide, we've also been able to extend a lot of our collaborative partnerships with other organisations, with social prescribing link workers, occupational therapists, Birmingham City Council's adult social care team and DWP, to provide a multi-purpose, welcoming community space. We opened in December 2021 in consultation with our communities to utilise our knowledge, as well as utilising our knowledge as social prescribers, and we're also leads for the Erdington Neighbourhood Network scheme. We currently provide lots of different services, from drop-ins for benefit advice and support, housing drop-ins, the occupational therapist have drop-in services, and so does the adult social care team. We also have different groups and activities that go on. So we have carers groups, domestic abuse, peer group supports, employment support and healthy eating. So there's quite a range around services we provide around training and volunteering, employment, benefits, advice and support, mental wellbeing, physical health and healthy lifestyles.
Yeah, no, that's great. Thank you. And I know you have been so busy at the hub. It's been really, really good, hasn't it? And just before we finish up, if you could share just a couple of the impacts, though. I know you've got some figures around the idea of how many beneficiaries you think you've supported over the last couple of months. It'd just be great to have that info out, if that's okay.
Yep, so literally from January to September, just at the Erdington Hub itself, we have supported 1,599 different members of the community that have come in for a range of services. So the impact is, well, the numbers say it all really in regards to the impact. And the wonderful thing is that we're continuing to grow and develop what our services are. We're at Monday to Friday. So the lovely thing is that we're there every day for people to either drop in and or get some information and support, but also connecting with the work that we do with our social prescribers and through the Neighbourhood Network scheme.
Lovely. Thank you so much for joining us today, Debbie. I hope that gives you an idea on how NHS Property Services are using their vacant space for our social prescribing programme. I'm going to pass back to you, Tony. Thank you.
Thank you.
Thank you both. Really great to hear that, and great to hear about Whitton Lodge, because Whitton Lodge is a locality member. So it's good to hear what you're doing, Debbie. Okay, so next speaker up, Bridget Gill, who's the Chief Officer of Spectrum People, and Bridget's going to talk about models for community ownership. So over to you, Bridget.
Thanks very much. And if we go straight on to the second slide, please, Neil, that would be great. Just to introduce myself, Spectrum people are based in Wakefield in West Yorkshire, and I've got a background. I've run Spectrum people for about 10 years, but before that I did work in the NHS. Actually looked after buildings at one time, but also did some work on patient and public involvement. So it's very kind of much in my heart and my experience of using space to best effect to help people. So we've been going 10 years, but just to add to a couple of things on that slide, we've got a reputation for getting things done and for partnership working. So hopefully that problem solving that we've been talking about earlier. And we also talked about lived experience, and we do very much try and give people with lived experience, allow their voices to be heard and supported. And that's by real active listening to them and using what they're saying to develop what we're trying to do. We're very grounded in our communities, and I'm going to talk about two particular spaces, both within Wakefield and its wider district. And we often describe ourselves as a floating anchor. We go to the spaces where people's need is greatest and where we can deliver the most. So on to the next slide, because pictures kind of tell a lot more than I can do in the words. One of the big spaces we use is Apple Tree Community Garden. It's 130 metres by 30 metres. There's everything there from a kids' play area so that adults who are there know that their children are safe and secure when maybe they want to talk. We've got an outdoor classroom, we've got some raised beds, so it's very accessible for anybody. We've got quite a few people who are wheelchair users who come there. Lisa, who sows everything's grown from seed, and her green fingers, it's amazing what she can grow. It's just fantastic. But I guess what we've all learned through COVID is how important green space, the great outdoors is, and how much it can do for our well-being. A lot of people come direct to the garden gate, and when they're there, they say that they leave their problems behind them at the gate. And maybe they want to do a bit of gardening, maybe they just want to have a chat. So we have a Tuesday community lunch with stuff grown from the garden that's used as the produce. It's just really important that people can do what it is that they want to there. On to the next slide. There's a few facts on here. If Neil could move it on, that would be great. So this isn't a quick thing. It's taken us 7 years so far, and it's still really developing. But you can see the amount of volunteer hours there, and that is really, really important. We've got many volunteers with lived experience. They go on to be peer supporters, and that was talked about earlier on as well. We're not open every day. I wish we were. We have a community group. We're trying to get there. We've got a guy on a Sunday who goes down and talks to our rescue hens, telling them the football results. It can be anything to all people, but it's beginning to grow into something much more. So we lots of groups use it. National Citizen Service, Princess Trust, the Probation Service. We've had people there with from the prison service, with the wardens there as well. One guy came along, he'd got brand new trainers on, and they hadn't told him he was going to be digging all day. That was quite interesting. Art groups love it. We've got reading groups, drama groups. We've had birthday parties. We've had faith groups using it. We've been approached because a couple of people have said they'd like a wedding there. So that's a new thing for us that we're trying to learn from. And we will continue to develop it based on what we hear from people. The second, just to mention as well, what's the model? It's owned by Wakefield Council, but it's a service level agreement with Spectrum people. I'll come on to that later because I think it's really important about who it is in the community who runs something, not necessarily the people who own it. And that's been talked about already. The next slide is the second space I wanted to talk about. This is newer to us. It's called Teve Tara, and it's in the Airedale area of Wakefield. Airedale is one of what are called the 5 towns outside of Wakefield itself. And if I just mention these names, Pontefract, Normanton, Ferrybridge, Nottingley and Castleford, they're all ex-mining areas. And that's quite important because it still resonates in the area, and it's something we always have to be mindful of. People have mentioned this earlier, but transport is expensive, irregular, unemployment's high, hope is very low. And what we're trying to do is not to do what's happened in the past, where somebody comes helicoptering in, whether it's an organisation or a project, disappears, and whatever hope that had built up is just destroyed. We hope to be there for the long haul. It's not owned by NHSPS, it's another of the estate handlers, but in fact the people who run it now are the parent umbrella group for Spectrum people, which is called Spectrum Community CIC. And I mean, it's an interesting building. If we just go on to, I think it's the next slide, yeah. I've got 2 social prescribers who are there, employed by the charity. That's normally they're always employed through the NHS, but we don't get funded for them at the moment, but they're doing loads of excellent work within the practice. I've got an art therapist there, many partners, because we can't do this on our own. It's got to be co-produced with lots of voices, people from the community, maybe other small charities, but we try to listen actively to what everybody's saying and what they want. And we do work obviously closely with the GPs. The lead GP at the practice is actually the health inequality lead for the local PCN, which is really helpful. And there is obviously a patient involvement group, so we wouldn't try and set something else up. We will go out and talk at the local galas and things like that, but we will be trying to pick their brains and find out what it is that's wanted locally. The next slide shows a bit more of the building. It's an interesting building. It's got this huge archway. So it's got its idiosyncrasies, I think we could say. There's also one corridor which is known as the cold corridor, and I'm trying to make it a lot warmer with some artwork at the moment. But that archway, I'm using it kind of, it actually leads to a quiet area. So we did some great video filming there earlier in the year. We've run Sing It Out Mama, which is for mums and their babies. We're running maternal journal. We've run cookery courses there. It's not ourselves, but another charity runs a mini gym at the back, because actually there's a separate entrance through that archway. So it doesn't impinge so much on the practice, but it can be developed as a community space. Lots of potential and issues to overcome, but that's the problem solving again. So what have we done overall? On to the next slide. We do, I think I've said it before, but we actively listen and engage, and we reframe all the time. We change. My trustees often say to me, why do we change so often? Well, we change because that's what people say is needed. And we also do positively challenge quite a lot. I'm known for, my team say I have sharp elbows because I kind of ask questions all the time. Also not making assumptions. And I think when you're in the public sector, and you're not really into that community, it's very easy to make those assumptions and come up with something wrong. So there's a couple of things just to add here. Whomever leads on developing a space shouldn't necessarily be who owns it. They need to kind of empower the people that need to do it, but it's probably them that are not best placed for that. Also, it isn't possible to directly replicate. Nothing will replace that local time, involvement and knowledge. Another thing for me is relationships are kind of win out over systems every time, but the NHS does love a system, and that sometimes can cloud the issues. I was also really interested in the shirt and tie talk, and I was thinking, oh yeah, when I was in the NHS, I typically did that. But there is something which I think is important, which is about, we do sometimes need to use slightly different language. There's an awful lot of jargon in the NHS, but if I'm, say, talking out at Airedale Gala, I probably will be using slightly different terminology. And certainly when I'm talking to my clinical colleagues, I'll need to use some different terms. And I don't think it's masking, but it made me question myself earlier on when that came up. And the last point I really wanted to make was the voluntary sector, like anywhere else, doesn't run on air, and we need to be sustained. And that bit about hope and the helicoptering in and then it disappears, that's all too often because the funding goes. So it's so important that we get that sustainability. And I've used, I know, a few slides, but the very last one, because it says much more than I can do again. The lady 3 along with the cap on, Dawn, she's a really strong advocate. She's a poet. She didn't know she was, but she is a great poet and artist. And she nominated Spectrum people. She also did that picture on the side, the washing line together in a park. That was I can remember having a conversation with her during the first lockdown, and she's saying, I don't know what to paint next. And I said, well, look out the window. And she said, there's a clothesline. And that was during that first really difficult part of COVID. And we were supporting her, ringing her 7 days a week. But what she nominated us for, and it kind of said it when we won that award, we're very small, but we try to listen really carefully, and space and using it to best effect is really important. Thank you very much.
Brilliant. Thank you very much, Bridget. Another great locality member, so did the shout out. Really interesting what you were saying there about the different models, the feeling of control, and the longevity. I really liked what you said, which really resonates with me, about you're in it for the long haul rather than just helicoptering in. And I think there's too much of that in the sector. You know, people pop in, bits of money appear, bits of money disappear again. It's very disorientating. We really just need to invest in long-term work at a local level, and that's the kind of work that you're doing. So thank you for sharing your contribution there. Really good. Okay, so we're moving to our last speaker for the moment. So before we move into our breakout groups, so get ready for that. So delighted to welcome Mel Jacobson, who's the head of healthcare at HLM Architects, who are supporting this series of events. So welcome, Mel.
Hi, thank you very much for having me. So I'm going to probably talk about a few things that we've already touched on today. I'm really lucky that in my role as head of healthcare at HLM, I've been fortunate enough to be able to engage with the Health Creation Network. We're an architectural practice with over 40 years of working across the healthcare in the UK, and we see health creation as fundamental in providing a sustainable approach to healthcare design. So for this part of the session, Merrin kindly asked me to provide a few words on the role that design plays and what we have engaged with today. So if I could have my first slide, please, up. Great. So this is Cynon Valley Community Hospital, Cardiff. It doesn't feel overtly clinical. There's art, there's colour and materials, and it's more aligned to a public building. It's a large space, but the principles of this would apply for a smaller, more intimate space. But you'll note the absence of people in this slide, however, and I'll come back to that later on. So I wanted to talk about what is in design that impacts on us as human beings. In very broad terms, design is a two-part process of engagement to establish a brief and then to develop a product to meet the brief. If the main content of the NHS Property Services report focuses on what is needed, I wanted to touch on why it is that design impacts on us as human beings, and moreover, how this is important. Good design is a complicated process, and being presented with a situation, unravelling the problems intricately to provide a fitting answer to several questions. Designers creatively problem solve a wide variety of difficulties across a realm that covers everything from door handles to new towns and cities. In my years of practicing as an architect, I've been asked a number of times what it is that makes design and architecture special, rather than just an object or a piece of construction. For me, architecture and good design generally evokes a positive response and has the ability to move us emotionally. I'd even go as far to say that good design touches the soul. But we also know that design and architecture can get it really wrong. We can superimpose ideals that can create the opposite anticipated effect and instigate social issues that are highly negative. It's therefore really important that architects cultivate skills that earn trust. We know that our buildings shape the environment around us in a multifaceted way, and as we grow ever more complex in our needs, good design has to reflect this. So earlier, somebody mentioned the sort of complexity of COVID, and I recently heard it described as a pandemic with further pandemics within it. Predicaments that have been simmering below the surface for many years have come starkly into focus: our mental health, social inequality, racial tensions, community isolation. And now we've got further issues causing concern: gaps in education, burnout, the cost of living, economic and political uncertainty. There's so much currently that needs to be considered. It's often struck me as really ironic that the very buildings we go into to get better often have environments and atmospheres that promote exactly the opposite feelings. For years, healthcare architects have been diligently working to the HBNs and HTMs, these are the healthcare design guidelines, to provide spaces that are deemed suitable in purely clinical terms. The net result has often been a plethora of signage, wipeable vinyl, and an abundance of coved skirting, functional, cleanable, unemotional, and often downright dismal. It might sound obvious, but it's incredibly important that when we walk into an environment for a specific purpose, the success of the activities that take place within these spaces is highly dependent, not just on the facilities that are provided, but the way in which we feel when we're using these facilities. We all recognise that when we feel uncomfortable in our own skin, we're not going to be receptive. Therefore, the environment within which we find ourselves plays a huge part in contributing into how we interact with each other. However, how does this connect to well-being? What is well-being even? It's used in abundance nowadays, and it seems to become the go-to word to describe a state of being that's aspired, desired, and desperately needed. Early this year, I was at the European Healthcare Design Congress, and I watched a session called Neuroscience and Healthcare Architecture. And it used the term emotional regulation for the neurodiverse, which, while sounding a bit clinical, struck a chord with me. In more simple terms, my definition is this is the ability for any individual with their own personal needs to be able to manage their emotions for a positive outcome. To me, this is well-being. And therefore, even if we provided a bright, shiny new functional building, if we do not also, as architects and designers, consider the soft design aspects around promoting well-being, we are straight away undermining the very goal of the design. As such, we're now beginning to see an influx of design requests to inject well-being back into buildings. We can look at the guidance that sits well within the WELL standards or other toolkits that address well-being. We can take into account wellness factors, good environmental control of light, air quality, temperature, noise, incorporating design features that we know enhance how we feel through connection to landscape, biophilia, colour use and art. But most importantly, the spaces need to provide comfort for all and a safe place to meet. And here the design must be inherently flexible with large spaces, small spaces, noisy spaces, quiet spaces. If I could see slide 2, please. So this is just a very quick mapping exercise that we're doing for a trust at the moment. We're looking at the WELL standard areas, which are on the sort of right-hand side. We've added in sort of 3 other criteria. We've actually added in safety, nature and art as specific areas that this NHS Trust feels that it's important to incorporate into their design that we're doing for them. It's just to sort of demonstrate that there is guidance out there about well-being specifically, but it's not prescriptive. It's not a done deal. There's so much more that needs to be done through an interaction with the community that you're designing for. In the NHS Property Services report, it mentions that people need physical spaces to connect with others, emotional spaces to reflect, and system spaces that enable people to access services. There's a line in the report that also says, don't assume or presume what is needed, ask the individuals concerned. We as architects cannot possibly understand the users if we do not go under the carpet of the community. And by community, I mean not just the visitors to the building, but the staff as well. By engaging first, listening and responding, there'll be much greater likelihood of a project success and a truly sustainable approach upon properly laid foundations. So much of well-being is about people being heard and seen whilst maintaining the privacy and dignity and ensuring they feel safe and comfortable. We need to keep the design focused, people centric. It's clear we really need to understand the people who'll be walking through the front door, or in some cases struggling to walk through the entrance. This is both understanding the individuals and the collective groups. The report talks about the appropriate spaces being provided for cultural expression of individual community groups, but also allows for different activities and the opportunity to mix and meet different people. The focus on common factors, what unites groups as well as individual needs, allows flexibility to be designed. We know that if we include the common elements, we'll be able to create a place that can be shared collectively or used individually. In saying all of this, some of the most successful community spaces I've seen aren't highly designed spaces. Importantly, they're spaces which have become places for relevant and needed interaction. They work because someone took the time to find out what was actually needed, what problems had to be solved, and through engagement, allowed the community to design and evolve a vision, working collaboratively together for a greater positive outcome. If I could have slides 3, please. So just a couple of slides here where the making of a place has become key. And this is Edinburgh Royal Hospital for Children and Young People. It's an HLM project. And it's where we use play and interaction to distract both the parents and the children from a serious clinical setting. And we also allowed individuals to interact with the space to feel comfortable. And then the second slide, please. The next slide, please. And this is actually an Undercroft, a major dual carriageway that bisects the University of Sheffield campus. And here we took something that really wasn't very nice and a bit of an obstruction and viewed very negatively into a place with potential that gives shelter and a place to meet. And trying to sort of demonstrate the opportunities here that design can really transform spaces into something so much more than just a room with 4 walls, a floor and a ceiling. If the report and the previous speakers have highlighted what detail and data information can be obtained through listening to communities, I hope that what I've mentioned, understanding is being conveyed to the lens of a designer as to why it is so important and fundamental in providing a basis of design for community spaces. I just want to reflect briefly on what's been discussed so far today. A couple of things that have jumped out at me are things like terminology, moving away from a clinical language. I also think there's a definite cross-section or cross-sector applicability that we are looking at healthcare environments here through the NHS typically, but actually we can learn from commercial sector and the education sector. It's all people at the end of the day. We need to create buildings that are fit for purpose. Access is being talked a lot Access is being talked about a lot. Access for everyone, is not just a disability issue. And problem solving, leadership, trust have come up a lot. Authenticity, I love the shirt and tie conversation, or in the case of architects, it's a black polo neck and odd glasses. We've heard from Rachel Ann and Debbie about growing and developing and needing a flexible space and every day being open, and that consistent and caring approach which then builds trust. Contrast, we heard from Bridget, who said that she wishes they were open every day, and she also said that hope is low, but that people who are leading and designing space didn't necessarily need to own a space. These are all issues that kind of touch on design. I think it's also worth touching on sustainability in a wider social or economic sense. There's a saying that unsustainability is a design flaw. We want to create places that will be more than just fit for purpose and that can be agile, flex and adapt to suit the needs of people who use them. But most of all, we want our buildings to have a positive impact on their surrounding and make a better place for people. I think everyone that's involved in health creation wants a way forward that is meaningful, authentic, impactful and will last. As part of this talk, I was asked to kind of start to touch on what a call to action might be. And earlier in July this year, the CCGs transformed into the integrated care boards with integrated care systems. And the aspiration of this change is to bring the NHS healthcare back into working with the local community to help tackle health prevention within neighbourhoods and alleviate pressures on the health treatment facilities and hospitals. The success of this transformation is heavily rooted in health creation. It will
Sorry, Mel, you've become muted. Can you just unmute? Sorry about that.
That's okay. It's
great.
fine.
Thank you. That wasn't a time.
That hint.
That was a genuine error. So sorry, Mel.
That's fine. No worries. So where was I? I was talking about ICSs. So the transformation of this is heavily rooted in health creation. It's only through working with the context of close community contact and allowing communities to grow in confidence that they're being seen and heard, and ultimately through this to gain control and meeting their needs, that healthier lives can be promoted. But communities are infinite. Unlike a project, they don't have a start, middle and an end. They're constantly evolving, ebbing and flowing. Currently, service providers for a project represent a finite process superimposed onto a situation. This can jar and it can block against the evolving needs of a community. If health creation starts with a connection and a relationship, then trust must be the underpinning factor. We need to foster trust again, and we need to find a way of listening to all of our communities and blending the interface between service providers and service receivers, especially in areas which are underserved. With this in mind, a call to action could be the establishment of a framework of trusted health creation network partners within the integrated care system to provide a holistic community engagement process that seeks to understand the what and transform it into the what if. In the words earlier from George Fielding, invest early, invest wisely, it pays off. And then everybody has a responsibility. So if I just go to the last slide, please.
Yep, 1 second. That, I think that was the last slide.
That is
that's it there.
That's it there. So this is the same picture as the first slide, but the photograph was originally taken, we had no people in the first image. And whilst this picture was taken without patients, we were actually able to engage with the staff for a shot. Our building's relevance, the design comes from the people. That's why I've put this in. It's the people who use it that give it its meaning. So let's ensure we talk and understand them better than perhaps we have done historically. Thank you very much.
Thanks so much, Mel. And thank you to all of our speakers in that session. Really great insights. So lots of food for thought as we move into our breakout groups. But I posted in the chat some kind of what I've been trying to pick out, some of the themes that have been coming out from the conversation. So building on some of those. So disagree with me or agree with me on those, or add your own. This is a kind of collaborative space, and there's some really good comments in the chat as well, which I'm sure we'll be collating and using to take forward. But interesting thing on the kind of whole thing about ownership and kind of, you know, this turning spaces back into community use and kind of using perhaps derelict buildings or old buildings being renovated and all of that. You know, that's something that we've seen, really the power of being able to do that kind of thing with community owned spaces. So money being available, partnerships being available, particularly with NHS actually, to say how can communities be in control of these spaces and use them for different purposes in a local community. They become much loved, much supported buildings, which can then be a hub for service provision in the local area. So we do have to think creatively about different models. Can we do long leases for communities to take on control of things? Can we give money to existing community organisations through renting their services, renting space from them, rather than trying to think it only has to happen in public service buildings? So really interesting stuff coming out. So we're now going to move into the breakout groups, and to introduce what our task is in this session is Lee Morgan. So Lee, welcome, and you're going to tell us what we're now being tasked to do.
Oh, well, that sounds far too prescriptive for me, but there are some guidance, and it's some of the questions to think about in the room. Why do you think multifunctional community spaces used by many different groups are so popular? And how might spaces be managed to maximise cross-community mixing and activities while also allowing specific communities to come together by themselves? And another question, how might the NHS make sure development or redevelopment of a space is adding to what is already present in the locality? And then to take some time about the call for actions. I think we've had quite a few call for actions today, and it'd be great to pin some down. You're going to be invited to join the breakout rooms with a little button, and I think we'll be in there for about 15 minutes, which so far has felt too short. Okay, thank you very much, Lee. And also, so you'll have, then after about 15 minutes, you'll be given a 5-minute notice that it's ending, and then we'll bring everyone back to the room. So thank you very much, Lee, and you're all going into your rooms now.
Okay, welcome back, everybody. Always cut off in our primer conversations in breakout groups, aren't we? So hopefully you got something interesting from that. So I don't know if we've got time to do specific feedback from each group, Maren. I'm kind of looking at you. Probably not, because we've only got a couple of minutes. But I'm assuming that we're going to capture the feedback from these sessions from the facilitators and report back. Is that right? Okay, so I mean, some of the reflections then that I've had, so it's been an amazing couple of hours. It's flown by in terms of the conversation that we've been having. And I think I felt really kind of inspired and hopeful, I think, that better partnerships can be created in the future. I think there's real experience, there's real expertise, and there's real authentic voices that are being heard, I think, by the services that we need to hear us. And so it fills me with some hope that we can kind of take this work forward and develop proper partnerships that can actually understand the needs of people in making our spaces accessible and inclusive for the long term. So there's a few things that I just wanted to say by way of summing up. So we wanted to say, first and foremost, thank you to all of the speakers. I'm sure you'll agree, everybody has been really great, both in terms of efficiency. Everyone's been amazingly good at speaking to the time, as never happened ever before in any event. So you're all incredibly well trained in terms of your efficient contributions and being really succinct in what you're going to say. So thank you. But the insights and the content has been incredible as well. Thank you again to all of the partners and sponsors who've supported Coming of Age. And just to remind you, National Health Executive and Public Sector Executive, HLM Architects, NHS Property Services, Novartis, PPL, Solace, South Central West, and the Health Alliance's patrons, Lord Victor Adebowale and Lord Nigel Crisp. So thank you for your time commitment and taking part in this, and particularly those of you who've been involved in the research and the development of this work and the reporters at all. A reminder to sign up and join the Health Creation Alliance, and the link I'm sure will be circulated again. It's already been in the chat as well. Do include the take part in the evaluation as well, so that we can get your feedback on how the event has gone as well. Do check in with the other events that are coming up in the programme summary, and also the call to action. Remember the call to action. So I think what's happening now in the process is that those ideas of potential calls calls to action are going to be thought about, played around with as a result of these events, and then replayed back to us at the end of the event series. And so hopefully that will really help us coming up with some solid recommendations about how we can actually achieve change and seek better things. And our aim is to move people from being passive recipients of knowledge into change agents. So the calls to actions are intended to help crystallise how people can take action to support health creation wherever they are in the system. And I think that's a really neat way to end this session. So hopefully you've got a lot out of this session. Thank you again to everybody for being involved, and look forward to seeing you at any of the other events.